Hi everyone, I hope you can hear me okay. My name is Emma Feeney. I'm the Head of Global Advocacy at the George Institute for Global Health, and a very warm welcome to everyone joining us today from around the world. I'm delighted to have so many of you taking part. For those of you who aren't yet familiar with it, the community on Women and NCDs is a virtual community facilitated by the George Institute with WHO's Global Coordination Mechanism on Non-Communicable diseases. And the aim of our community is to share and promote best practices in implementing a life course approach to women's health. We have a fantastic steering group that I'd like to thank, a range of experts from around the world who provide us with ongoing input and support, and you can see their names up on the slide now. I'd also like to thank my colleague Alyssa Chasefield-Chairs for all the hard work she's put into organising this webinar, and WHO's Global Coordination Mechanism for all of their support. So this is our third webinar in an ongoing series, and recordings of the previous two webinars are available, so take a look if you missed them, they're well worth a watch. And today's webinar comes just after World Mental Health Day, which was established by the WHO as an opportunity to encourage conversation about what needs to be done to make mental health care a reality for people worldwide. So today we're going to focus on depression, an NCD which afflicts more than 300 million people globally, and it affects twice as many women as men, according to the WHO. Our speakers today will include a mental health advocate who will share her personal story of battling stigma, medicine shortages, and other barriers to accessing depression care. And we'll also hear from three practitioners from around the world who are going to provide examples of cost-effective prevention and treatment options that reduce and counter depression, and that are both culturally appropriate and gender sensitive. So I'd like to flag that this is an interactive webinar. Please do enter your questions and comments in the chat box throughout. You should be able to see that at the bottom of your screen, a little thing that says webinar chat box. We should have plenty of time for discussion at the end, and we'll do our best to answer all the questions you have in the last 20 minutes or so of the webinar. Also, we'd like to flag that the webinar will be recorded, and we'll be sharing a link to the recording afterwards with everyone who's registered. And at this point, I'm going to hand over to WHO's Global Coordination Mechanism to start today's event, because we're going to spend a few minutes just hearing about the Knowledge Action Portal set up by the WHO, which hosts our community on Women and NCDs. And the portal has recently undergone some really exciting updates. And so I'm going to hand over now to Jack Fisher at the Global Coordination Mechanism, and he's going to tell us a bit more about them and how everyone can engage with this community through the platform. So Jack, over to you.
Thank you very much, Emma, and hopefully everyone can see my screen now, which actually gives you a live view of the Knowledge Action Portal. As Emma mentioned, my name is Jack Fisher. I'm a technical officer here with the GCM for NCDs here at WHO. And as many of you know, the community on Women and NCDs is linked to the Knowledge Action Portal, and this is really a comprehensive online platform for the NCD community to not only receive information, but also to interact with each other and ultimately become inspired to go forward. And we really hope this is a resource which can support your respective efforts. The community previously has been on multiple different platforms, but we've actually recently revamped this to really change it into a much more dynamic, interactive space. And hopefully I can walk through some of the key updates onto the new platform. So as you can see here, this is the new homepage for the community on Women and NCDs. We've included these 5 key messages, which again are all the content you can see here is really customized for each community by the relevant moderators. So hopefully this gives you an easy, accessible overview of what the key messages are for that particular community. On top of that, we've also included a new events calendar. So here you can see all the previous events which have taken place, alongside what upcoming events will take place across 2019, 2020, and such forth. And of course, we also had a new section which really tries to map not only what the community is trying to focus on in terms of the concept and vision, but also highlights those steering group members, which Emma rightly pointed out at the start. It's a really key asset of these communities going forward. Of course, if you want to find out more about the George Institute, then you can have see a short description there. And then of course we have the notice board. And again, this is one of the ways that we want to try to present some of the content which is shared within communities and between communities in a very interactive format. So this really follows a similar style to Pinterest, where different content can be presented in a dynamic and interactive format. Some of you may be familiar with the discussions, which have previously been the kind of staple, if you like, of communities in the past. These still exist. And I'm sure that there'll be ongoing discussions which will be linked to webinars, to other types of activities in the future. So be sure to have a look at these. These are still open, so if you wish to contribute and add some comments, then you can do so through that area of the communities. And of course, if you have a question, and then you can submit that via the submit information section as well. Two quick things just to highlight as well, as being quite significant additions to the site. As you can maybe see in the top right-hand side of the screen, there is now the functionality to not only view all of the content within the communities and the CAP in the 6 official UN languages, but also gives the opportunity for different users of those 6 languages to contribute content and ideas and comments in the discussions as well. So we really hope this is one of the tools which can be used to broaden the accessibility of the platform as a whole. On top of that, we also have our new virtual assistant, whose name is Ari. So this is again a virtual assistant which can answer some of those questions if you wish to speak to a virtual assistant rather than us at the Secretariat. So hopefully that gives a bit of a quick overview of what is new within the platform. And we hope this can support your efforts going forward. Thank you very much.
Hi, thanks so much, Jack. I hope everyone can hear me okay. That was great update. Thank you for sharing that. At this point, I'm going to hand over to our moderator for today, who's going to guide us all through the rest of the webinar. And I am delighted to say that our moderator is Dr. Rochelle Burgess. Dr. Burgess's current research program explores the role of community engagement in global health with an emphasis on women's mental health. She's interested in promoting interventions that combine attention to social determinants of mental health, mainly poverty, alongside psychological and psychiatric care, primarily in the Global South. She is a lecturer in global health and Deputy Director of the UCL Centre for Global Non-Communicable Diseases at the Institute for Global Health at UCL. She's also the founder and director of UCL's Global Network on Mental Health and Child Marriage and UCL's Global Mental Health Network. Rochelle is a Fellow of the Royal Society of Public Health, a member of the ESRC Peer Review College, and a member of the NIHR's Global Health Community Engagement and Involvement Advisory Network, among many other affiliations. She holds a PhD in social psychology and an MSc in health community and development, both from the London School of Economics. And we are absolutely delighted that she's able to moderate our webinar today. Rochelle, the floor is yours.
Great. I think I'm unmuted, but I cannot see my face yet. Haha, there I am. Hello, everybody. Emma, thank you so much for asking me to be a part of the webinar today. It is a pleasure and a privilege for me to speak to so many people about something that I have been so passionate about for such a long time. So what I'm going to do sort of to start us off is have a brief sort of an introduction where I reflect on some of my experiences and some of my own work and how that sort of led me to think about about what sort of brings us here together today and these objectives that you can see on the shared screen, specifically to think about why women, why do women and girls need special attention, and when we reflect on depression and treatment, and what are some of the challenges that we face in trying to achieve that. I think it will be of no surprise when I say the statement that we live in an unequal world. It's one of the rare things that is an undisputed fact these days. And I think there are many ways that you can slice this inequity, but one of the clearest lines is along gender. And this inequality that I want to sort of reflect on today, specifically from the dimension of womanhood. And what is it about womanhood and what it means to be a woman or a girl in the world today that leads us to such staggering rates of twice as many women experiencing depression around the world. So as Emma alluded to, I'm a community and social psychologist. And what that means is that I'm very passionate about thinking about and addressing the wider contexts of society that drive gender inequalities for women, specifically when it comes to their mental health and well-being. And in my work over the past sort of decade or so, possibly more now, I try not to count because the counting makes me feel like I'm getting old. But essentially, I work in stories, I work in women's stories. And my work is very much interested in looking at how women who live in contexts of precarity make sense of their own experiences of mental distress and specifically depression. And a lot of these stories sort of reflect a world that is driven by unfairness for women. And when you look at data and statistics around that, it's not that surprising. So, for example, a 2018 World Bank report that was looking around gender dynamics of poverty across the life course essentially showed us that women's experiences at different times in their lives, things like early or forced marriage, low-waged work or access to precarious work, exposure to numerous forms of violence, low access to education, makes them more likely to experience and fall into poverty. But even accounting for these sort of life contexts, it doesn't explain what the authors of this report refer to as the poverty penalty, where they state that 5 million more women up to the age of 30 live in extreme poverty compared to men. And it's particularly the case in South Asia and Sub-Saharan Africa, where we will hear some of our stories and presentations from today. And in my work, these statistics like these filter through women's stories in their accounts of depression as inexorably linked to their inability to feed their children on a regular basis in South Africa, in Colombia, where women account for their depression as a result of sort of generations of life in protracted conflict and how that has made it difficult for them to work to ensure that their children have a better future than their own. And you know, luckily in most cases, there is a growing awareness of the links between poverty and mental health challenges, and specifically depression. But in other contexts and challenges that women and girls face, this relationship can be less acknowledged, particularly in the realm of services. So if we look at the example of violence against women, an issue that affects 1 in 3 women globally, there is surprisingly very limited attention to the mental health consequences of this practice, of this issue for women, particularly among health practitioners who might be seeking to support them through experiences of violence or sexual violence. This is compounded in contexts of conflict where women are more likely to be exposed to acts of sexual violence such as rape linked to war. And more recently, as I have begun to do work on issues relating to mental health and child marriage, I was struck by the very limited exploration in academia into the relationship between this very complex social and cultural practice that has huge ramifications for various other health dimensions of young girls' lives around their sexual and reproductive health. And despite an acknowledgement of the relationship between this practice and increased rates of self-harm and suicide, we really find that there is almost no attention to thinking about interventions to support women and girls affected by this practice through a range of mental health consequences that they may experience. And in a lot of cases, these contexts that drive sort of women's narratives are global. As I said, I've worked in South Africa and other parts of the African continent as well, increasingly in South America and parts of Latin America. But what separates, and also high income countries, and one of the things that separates the two is obviously the ability to access treatment and support and care around trying to manage the emotional and mental health consequences that these contexts drive. And access to mental health services, for lack of a better comparison, remains a luxury for many people in the world, a luxury of circumstance. If you are lucky enough to be born in a part of the world where services are available, or access to resources if you are able to pay for private care in parts of the world where mental health services are only available through those pathways. But I think in a lot of spaces there's opportunity for hope around some of these issues, hope that's manifest in a lot of the presentations that we will hear this afternoon about some examples of how we are starting to work to reduce the treatment gap through developing cost-effective resources that amazingly draw on the resilience of communities that support each other through crisis. And I think increasingly there is an awareness in sort of global spaces of the importance of the community and community resources to ensuring good mental health and reducing depression. And so I'm really excited to be able to listen to some of these stories of success and survival, in the hope that these now become the stories that I become more exposed to in our work and in all of our work. And so the hope is that after today, we'll have an opportunity to think in a bit more detail about how we can replicate and expand some of these examples all over the world. So I think that's enough chat from me. What I would love to do now is invite you all to sort of participate in a discussion that we're going to be having with Grace Gatera, who is a youth campaign team leader for the recent Lancet Commission on Global Mental Health and Sustainable Development. And what will be a really powerful account of some of her experiences as a mental health service user in Rwanda. So, Grace, are you there yet?
Yes, I'm right here.
Hi, Grace.
Hi.
So wonderful to meet you. Just before we begin, I'm going to give a little bit more of a background to you for everybody else, so I don't have this to myself. And just to say to those joining us in our webinar today that parts of Grace's story may include references to various forms of violence and suicide. And so if these topics are a trigger for anybody out there, we sort of encourage you to think about taking a break for about 10 minutes if you would prefer not to sort of listen into our discussion about these topics. So Grace is a 26-year-old mental health and NCD lived experience advocate who's living in Kigali in Rwanda. She's the communications coordinator for PIH Rwanda, Inshuti mu Buzima. Have I said that right, Grace?
That's really good.
My little bits of Zulu for my PhD allow me to do some things okay. And services as a youth leader for My Mind, Our Humanity, a youth campaign for the Lancet Commission on Global Mental Health and Sustainable Development. Grace strongly believes that vulnerable groups must have the right to access specialized, high-quality mental health care and medication, and must be able to participate in high-level policy and decision-making. In her spare time, she loves to read female detective novels. And Grace, I think that's amazing. I wish I had spare time to read anything. So you can give me a list and I can and maybe start reading for fun again. So I wonder if you could start off by telling us a little bit about your story and you. Have you always lived in Rwanda? Sort of what brought you to Rwanda?
Thank you so much for having me. No, I actually moved to Rwanda 2 years ago. So before that, I lived in Uganda full time. I lived in a little place called Hono, 2 hours away from Kampala. And yeah, that's where I lived. And I think from a very young age, I knew that I had a mental health problem because my parents survived the genocide against the Tutsi in 1994. And as a result, I was diagnosed with PTSD from fleeing with my mother. So I was diagnosed at around 2 to 3 years of age because I was, demonstrating a trauma. I'm not a professional, so I don't know how that exactly works, but yeah, that's when I was diagnosed. And as I grew up, I got to get diagnosed. I became diagnosed with major depression and anxiety, and then later with panic disorder. So by the time I was 20 to 25, I I knew that something was wrong, and because I had been having suicidal thoughts for a while, and then when I was 23, I was sexually abused for the first time, and I attempted suicide, and then yeah, and then I think a year later I attempted suicide the second time. So it was, yeah, that's my brief story, living with my mental health disorders.
Mm. I can imagine that in Uganda that would have been very difficult in sort of trying to navigate a service landscape and gain access to care. Could you talk a little bit about sort of how you began that pathway to access treatment? Did you talk to family members about how you were feeling? How did that manifest in your wider community?
So despite being diagnosed with PTSD, I received no medical care because there was a huge stigma around receiving care for mental health issues. Because if you received care, clearly you were, what people here say, mad or or not okay, and I think my parents thought about a 3-year-old getting on mental health care, and they're like, no, that can't happen. So for a while, I didn't manifest anything more, sad. I wasn't a stereotypical, like, I don't know, sad person. So I was able to get away with no medication. But as I grew up, the stigma became realer. And when I started having my panic disorders, I started getting gaslighted. Is that a thing? Like gaslit into believing that I was pretending. So for a while, I also believed that I was pretending to have problems, that I needed attention, that this was my way of, being cared for, getting attention, and I totally got into denial about seeking help until I attempted, suicide the first time, and I was like, oh yeah, I clearly need support. And this was really late into my mental health journey. And yeah, that's when I thought, okay, I need to seek help. And I spoke to someone, and I got help, but I was at a very bad state. I was in a very bad state when that happened. Does that answer your question? Sorry.
Yes, no, it does. And what would you say was when you did get treatment? How did your family and friends kind of respond to that?
So a lot of my families don't know, family members don't know that I receive care, mainly for the same reason that had stopped me from getting care for a very long time. Because when you're having, in some places in Uganda, mainly in Uganda, having mental health issues is, to them, it seems like you're demon possessed, or it seems that you are mad, and you know there's this incredible stigma. So seeking help is equating yourself to being demon possessed, and I was very terrified of being associated with that personality. I didn't want to be demon possessed, you know, and so so that's one of the reasons why I delayed. And the family that I told, they still find it weird, which is fine as long as I'm fine. You know, it's like I don't care. But yeah, only a few people in my life are supportive about me getting mental health care, despite the fact that it's important, and despite the fact that Rwandans have suffered with so much and they need that support. There's just a stigma around mental health care that makes it very hard for a lot of people to access it or to seek for it.
And how would you say having access to treatment changed your life? That moment when you sort of were able to transition to care and gain support finally. How did that?
I think. Thank you very much. I think I was able to become a member of society again, because I mean, everyone knows the symptoms of major depressive disorder, but living it was, you thought of yourself as part of the community, but you did not ever get into it. I isolated myself completely. I used to live in a house in the middle of other houses, but I did not ever get out. Or when I got out, it was like 10 or 11, just to, you know, to refresh on, I don't know, like to just get something to eat, because I'd gone like weeks without eating. And so everything stopped. School stopped, life stopped. I didn't have friends. I didn't seek out my family. My parents lived in another country, and they went almost a whole year without knowing what was happening to me. And so getting treatment, finally admitting that I had a problem, helped me to reconnect back into society in a meaningful way. And being on treatment has helped me function. You know, those pills make me go, and I'm very thankful for that.
If we sort of transition to talk a little bit about Rwanda, because I think that's where your work now is based.
Yes.
What would you say are some of the major barriers to accessing treatment and care in Rwanda? Are they similar to Uganda, or are they different? Or?
I think for a lot of African countries, stigma is one of the greatest barriers to accessing care. But another barrier is the awareness of it all. Sometimes people go through life having depression, but never knowing what it is. They hide it. They don't talk about it. If a family member has had it, they keep it within the family, and they're like, don't talk about this shameful secret. And that stops people from seeking care. And another barrier here is the affordability of mental health care, because while we do have the universal mental health, the universal health insurance, it only covers a little bit, like 20% of the care that you need. It doesn't cover psychosocial support, the counseling sessions. It doesn't cover therapy. Nothing. So I think the three biggest barriers in Rwanda, I can say, is a lack of awareness, presence of stigma. I can tell you examples of people that I've interviewed for my job who were locked up in this, ugly tin houses for 9 years because they had schizophrenia, and so that they don't walk around, but that stopped them from getting the care that they needed, and in some cases stunted their their mental health condition for good. So so it's stigma, lack of awareness, and the affordability of it all, and even the accessibility. There's plenty of options for mental health care in Kigali, which is the capital city of Rwanda, but elsewhere, when you go out into the villages, it's very rare for us to find counseling services or to even get the medication. It's hard. So yeah, so those are the ones I'd say. Those are the major, in my own unprofessional opinion.
No, your opinion is very professional, lived experience, and your work is what makes your opinion most valid, more valid, I would say, than many others. Just a couple more quick questions before we sort of then dive into the rest of the presentations today. How would you say your life as a woman, sort of an African woman, has shaped your experiences of depression living in both Uganda and Rwanda?
Thanks for the question. I was actually telling someone this. I went to an event on Friday, and someone approached me. I was talking about depression and my experience with it, and someone approached me and said, "Hey, how do you expect to be married if you talk about how you're depressed?" And then someone else just blatantly told me, "Hey, you're not depressed," and I was like, what? I was shocked, and I guess that's and the thing is, I'm relatively well educated. I speak well. I speak English, and maybe privilege plays a part in this, but I think as women, we are expected to be perfect. We're expected to have this perfect. We can't get sick. We can't even when, because of the caretaker type thing that we've been put under. We're expected to power through our issues, and that's a situation you see in Rwanda, where women were among the bigger population that survived the genocide against the Tutsi, and they were left to take over the helms of being caretakers. To big sisters became the main breadwinners in their homes. Women who suffered through abuse had to continue powering through to support the children that they bore, to support their siblings, or to my mother alone is taking care of like 75 different people who are not necessarily biologically related.
Right.
So as women, we don't talk about what happened. We don't talk about our issues. We don't seek care, because if we do that, we're afraid that our lives will stop. The people who depend on us will not have anyone to depend on. And this has also informed my experience as a woman seeking care in both Uganda and Rwanda. I think a bit of what made me very reluctant to seek care was, if I confess that I'm vulnerable, if I confess that I'm going through this, what does it mean for the people, my siblings who depend on me? And that's the same situation, especially for rural women who have these issues but still take care of their families. I think living with depression and other mental illnesses is a very hard experience. I feel like I've derailed, but
no.
I think, but that's one of the things that makes it the hardest for women who live with mental illnesses to seek care until it's very late. It's how much, the patriarchy and misogyny and just plain, like, we have so much that we have to do that we put that on the side. We're like, hey, if it's not a physical manifestation, then I don't care. If I'm not dying, then I'm going to keep working until I die. But that's a very harmful mindset.
Yeah. So very much this mindset of I can survive anything because I need to survive anything.
Yes.
Yeah. I think that's something that I definitely have seen and also felt personally my own experiences of in dealing with my various bouts of depression, coming from a Afro-Caribbean background. Those narratives are very similar, so they resonate 100% with me. The very last question. If you could say one thing to a woman or a girl who thinks they might have depression or is living with it right now, what would it be?
Sister, seek care. You're not pretending, you're not seeking attention or whatever people say, you're not demon possessed. Seek care. That's it.
Thank you, Grace. I've written it down. It's amazing and incredibly important. Thank you so much, Grace.
Thank you guys for letting me speak.
Okay, so it's now time for our first presentation of the afternoon. We're going to have Kari from StrongMinds, who is based in both Uganda and in Zambia. Is that right, Kari? And so Kari is the Senior Director of Programs for StrongMinds, which is an international nonprofit organization that is focused on improving the mental health of women in sub-Saharan Africa. In her role, she provides strategic support and technical oversight to StrongMinds operations to alleviate depression, working to help drive innovation, efficiency, and quality across program offices in Uganda and Zambia. Kari has extensive global health experience, most recently serving as a Director of External Affairs at the nonprofit product development partnership TB Alliance. While there, she supported funding and development of major clinical trials investigating TB pharmacotherapies. Before that, she was the Deputy Director of Programs at the nonprofit FXB International, where she supported community-based poverty alleviation and child survival programs in 10 countries. A Seattle native, Kari holds an MPA from Columbia University School of International Public Affairs and a BA from Amherst College. She's been trained in interpersonal psychotherapy through the Global Mental Health Institute at Columbia University. Kari, over to you. Thank you very much.
Thank you. I'm hoping everyone can hear me. Thanks again so much for having me. A quick note, it's actually pronounced Kari, which I'll say now, and then not to worry again. It's easy to get that wrong. So I'm thrilled to be here and tell you a little bit about StrongMinds. We actually have programs in Mukono. And so a few years too late, potentially, Grace, to help community awareness and providing community-based care for depression, but we have a presence there now, and one that we hope will only grow. So the next slide, please. So a little bit about StrongMinds and who we are. So our mission is to treat depression. Our focus is on depression in women at scale in sub-Saharan Africa. We provide group-based talk therapy to women and young women in Uganda and Zambia. That's our two-country presence at the moment. To date, we've treated more than 55,000 individuals, the vast majority of whom are women and young women. We do treat some men primarily as a way of giving access and providing support to the women who are in their lives and in their communities. The group-based talk therapy model that we employ is based on interpersonal psychotherapy, which is well-studied and evidence-based in the region. And the IPT itself is delivered by lay counselors and volunteers from the community at no cost to clients. So task shifting is a critical part of our work to ensure that the therapy is accessible and cost efficient. Our goal at StrongMinds is to work with NGO and public partners to provide this community-based and low-cost treatment for depression to women across sub-Saharan Africa, where millions of women, as we know, are experiencing depression, and only about 15% of them are able to access currently any type of care or support. Next slide, please. So I'll talk a little bit about the impact that we've had and how we're trying to learn and grow and continue to ensure that we are providing excellent care for depression for women. So the next slide, please. Thank you. So we at StrongMinds, as I said, we use interpersonal psychotherapy, which is very well studied. And to ensure that we are providing excellent and quality care, we use depression symptoms as our primary outcome, and specifically the PHQ-9, to understand how our clients do after they experience and complete the therapy. We collect PHQ-9 scores before the clients begin therapy, midway through the therapy, after the therapy ends, and then typically 6 months after the therapy is concluded. And our goal is that 75% of women who complete therapy will have minimal depression, or what we call colloquially depression-free at the conclusion of therapy, and that remission will endure for at least 6 months after the therapy concludes. So you can see the table on the left here of this slide suggests that we're doing reasonably well at that target. And the pie charts on the right show the most recent group of women who completed therapy, their depression symptom levels when they began and at the conclusion of the therapy. The next slide, please. We also look not only at the percentage of women who are minimally depressed when therapy ends, we also look at the overall average symptom change and decrease over the course of therapy, with the target that using the PHQ-9, which is a scale from 0 to 27, that we will have at least a 12-point symptom score change over the course of therapy experienced by the typical client. So in this, again, in this particular instance of the most recent cohort from women in Uganda, the average client experienced a 13-point decrease, which is clinically really meaningful. It's the number, but it also means an ability to function and to care for your kids and to understand you're not alone, and to have a little bit more ability to focus and to tell the thoughts in your head that are insisting that you are the only woman in your community who's struggling to pay the school fees for her kids, that in point of fact, that thought is an illness and is not in any way reflective of the reality of your situation in your community. In addition, we track a few additional self-reported metrics around women's general well-being and functionality. So for example, we track women's self-reported productivity and her presence and ability to work, as well as her ability to feed and provide educational support for the kids in her care as is relevant. Okay, next slide. So I want to now pivot a little bit and talk a bit about a program that we're just piloting in Uganda as of this year. It's just begun as of a few months ago, with a specific focus on young people and on adolescent girls and some boys aged 12 to 19. So adolescence, I think of adolescence as the cradle of depression. It's during adolescence and a young person's life, that's the time of their lives when they're most likely to experience the first onset of depression. An adolescent with depression is at greater risk for sexual risk-taking. They're at greater risk for school dropout. They're less likely to adhere to medication and less likely to be well nourished. And if they do not receive care and services at this time, then they're more likely to experience relapse and depression over the course of their lives, which of course is going to have a compounding effect on others in their lives as they grow and develop. So adolescence is a really important time. Anecdotally, StrongMinds had enrolled quite a number of teenage girls into our program who were 16 and over. And we recognized that the group talk therapy as it was being administered to an adult woman audience was not necessarily well suited to this population. It didn't match their reward-seeking brains and sort of the neurological conditions that make teenagers who they are, and it didn't necessarily match their schedules and the structures and the demands on their time. Young people in Uganda, for example, are incredibly busy. Their leisure time is actually quite short, especially when they're in school. And they have a lot of people who have say over how they spend their time and what they do. So their ability to participate in therapy and to keep going in therapy, which is really important to us, is not the same as potentially their adult counterparts. So we wanted to introduce a pilot talk therapy program into schools directly and to see if we could offer some basic psychoeducation to kids, to adolescents in the school environment, and then provide depression care for kids in need in that setting. Before we did that, we used a firm to do a human-centered design study where we worked directly with kids themselves to develop some tools that would help ensure that the IPT curriculum was engaging and fun and worked for them and met them where they needed to be and kind of fit well into their lives. So this photo here on the right of my slides, I'm hoping that it's not as blocked by the by the Zoom screens, is actually a photo of a prototype that was part of that human-centered design process, wherein one of the things that emerged really quickly in working with the kids is that it was really difficult for them to express their emotions. And so quite a lot of time had to be spent sort of setting the stage for that emotional literacy before the processing and the work of therapy could begin. So together with the kids, the firm worked to develop these sort of social media emoticon type emotion cards, where kids could actually kind of more quickly sort of say, here's how I'm feeling today. And so we rolled that out as part of therapy, especially in the first few weeks of therapy, with the goal that this would help to kickstart the process and to allow us to do more, cover more territory, and be able to spend more rich time with kids really hearing their stories and allowing them to work through the triggers of their depression in a more successful fashion. And a lot of these tools have been incredibly successful. So once this study component and the design component was completed, and in partnership with Save the Children and with district and school level staff, we began the pilot. We launched it in 22 schools in Wakiso district, which is the district that more or less surrounds Kampala. So it's a semi-urban setting. And we screened all interested kids who were over 12, of whom about 25% actually screened in, according to the PHQ-9, with moderate to severe depression. And of those, 472, together with their parents, consented to participate and were enrolled. Of note, of the 1,900 who were screened, about 50 kids expressed suicidal ideation as part of that process. And about 5 were actively suicidal and had a specific plan and specific means to end their lives and were referred immediately for care. Those are 5 kids who I think might otherwise not have received any type of care and intervention. So I just want to move to the next slide and look a little bit at some preliminary results. I want to qualify this by saying that these are our initial internal data, and so they haven't been validated externally as yet, and we have more data to follow. But with that said, we looked at symptom score change in those 470 kids who participated in the pilot. You can see here across the screen, we have their symptoms when they began the therapy, halfway through, and at the end. We noted that about 87% of kids who fully participated were minimally or depression-free at the conclusion of the therapy. And excuse me, if you look at the next slide, this is a measure of the average score change according to the PHQ-9, and we saw the typical student experienced a decrease of about 9 points as measured by the PHQ-9, which is, again, clinically meaningful and certainly something we were excited to see. The next slide, we will have more findings, some additional scales that we used as part of this pilot. We also administered a SCARED tool to measure depression and anxiety, both amongst kids and their parents. We used the Strength and Difficulties questionnaire, and to assess anxiety in particular, we used the Hopkins symptom checklist or portions of it. So a lot of that data will still be coming in, should be available in the coming months as we continue to complete that analysis. So in terms of sort of thinking, okay, what did we learn from this pilot and what are we going to do next? We're really thrilled that this group-based IPT sort of packaged for young people appears to be effective in reducing depression symptoms in a meaningful way. It seems to be very well received anecdotally. We've heard from students, from parents, and from school personnel quite a lot of enthusiasm and excitement about the program. When we initially began the pilot, there were 3 schools that declined to participate. They didn't have any interest and saw no need. Those 3 schools have now approached us and said, please, could you work with us this next school term? We were extremely thrilled that the effectively StrongMinds value proposition to schools, which was that mental health, believe it or not, is affecting kids' focus, affecting their behavior, affecting their health and well-being, and it's in turn affecting their ability to be students and to participate in the school setting. That value proposition was not even completely necessary. Schools were I think, really quick to grasp that mental health care sort of provided in this setting was something that would be of value to their communities, and they were quick to donate their time. So teachers supported the screening process. They were quick to donate space, and they gave us time in the school day to provide the therapy to the kids, which was an incredible resource for us and allowed us to reach the kids at a time when they had, when they would be available. And it helped to drive up participation quite substantially. So as we think about kind of where we go from here with regards to the pilot, we're really excited about expanding the program in Uganda, also into Zambia. We'll take and adapt those tools that were developed and the packaging for the therapy from Uganda and introduce it into Zambia in 2020, which is really exciting. And we hope to roll out a fuller and more universal for all kids emotional literacy and mental health psychoeducation curriculum and expand geographically within Uganda. Our vision for this project is that we can make a compelling case to public, officials that therapy in school for depression, that addressing depression in schools can be something that can be adopted and rolled out at scale. We're really excited to see where this goes. So with the final slide, I just want to express gratitude for the kids and my colleagues who were involved in the pilot, and also take a moment for those of us who work in the global health and global development community. Mental health is often regarded that we get to take care of or to tackle once the other problems of health and poverty have been addressed. And so I just want to recognize the George Institute, the World Health Organization, and the NCD community for giving mental health this platform and for giving it the attention and presence that I think it deserves. And so I want to say thanks for that, and also take a moment to recognize the donors who helped make the pilot possible. Thanks.
Great, thanks very much, Kari. Is it Kari?
No worries, don't worry about it.
You've got, it's written the exact same as a young cousin of mine and pronounced very differently. So
yeah, see, that's the difficulty.
Struggling with it, clearly, I apologize.
No, not a problem.
Kari, thank you very much for a great presentation. I'm sure there'll be lots of questions when we get to them at the end. Now I'd like to hang over to Dr. Pallab Maulik, who is the Deputy Director of the George Institute for Global Health India, as well as its new Director of Research. He is also an Associate Professor on the Faculty of Medicine at the University of New South Wales, Sydney, and a Senior Research Associate at the George Institute for Global Health's University of Oxford office. He's a trained psychiatrist at the All India Institute of Medical Sciences in New Delhi, and received training in public health at the London School of Hygiene and Tropical Medicine, as well as Johns Hopkins School of Public Health, where he completed his master's and doctoral training. He brings a wealth of experience to the Institute with expertise in mental health in particular. He has worked with the WHO, Geneva, on Project Atlas and other mental health programs, and clinically as a psychiatrist in India and Australia. His research interests include social determinants of health, particularly mental health services, mental disorders and international mental health, and intellectual disability. He is an intermediate career Wellcome Trust DBT India Alliance Fellow, and is leading a program called Smart Mental Health on provision of mobile-based affordable evidence-based mental health services in rural India. And he's going to talk to us a little bit about some of this work now. Thank you very much. I'll hand over to you.
Thanks, Rochelle, for that introduction. So if we could go to the next slide, please. So I'll start with basically laying the foundation of what the situation is in India, and I'm using a gendered approach here for throughout my presentation. So just came out only a couple of years ago, our first national mental health survey. I must be honest in saying that this was in no way a nationally representative sample, but it covered at least 12 of our 29 states. And what we found in that was that for depression alone, the prevalence was about, a lifetime prevalence was about 6%, with males and females roughly equivalent. It's, the results are slightly different from the international results, which show that females have almost twice the prevalence rate as that of men. It also is surprising because the results were also different from other studies that have come out of India, which actually go hand in hand with the international results. So I think this is something that still needs to be thought through. What we also found in that mental health survey that suicide risk in different states that were part of the National Mental Health Survey. In there, we found that males had an increased suicide rate. So males have an increased suicide, males have greater chances of completing suicide, but women have a higher suicide risk. So that is also a key factor about that one needs to keep in mind for women and mental health. The burden of common mental disorders, and this includes depression, anxiety, substance use and alcohol use disorders, was around 10%. Can we go to the next slide, please? However, given all that burden that we have, the treatment gap, or if we can define it as out of the people who have a mental illness, what are the number of people who actually receive any kind of care for mental illness, for their problems? In countries like India, that is about 75 to 85%. So roughly out of 100 people who have a mental disorder, only about 15 to 25 receive any kind of care, leave alone appropriate care. And some of the common reasons of being stigma, very few mental health professionals and project actors from WHO, if one flips through it, will tell that in low and middle income countries, you have anywhere like less than one psychiatrist per 1 million population. Lack of awareness about mental health and mental disorders in the community, and lack of what is an appropriate care? Whom do I go to if I have a mental disorder? Those are things that are absolutely lacking in the society. Next slide. So what we thought, and this goes back to the project that we are doing currently in India, is that we thought, okay, let's think about how can we use mobile-based technology to basically improve mental health care delivery across our rural communities. And this came about because India has one of the largest number of mobile phone usage in the world, just behind China, with 900 million people who have connectivity with the mobile phones. And so we thought of using that power to deliver mental health care and to bridge the gap about services that is there in the community. We also wanted to give this power to the lay village health workers so that they could be empowered to use this tool to provide care in their rural setting. Next slide, please. So that brought about this project, which was called the Systematic Medical Appraisal, Referral and Treatment, or the acronym being SMART Mental Health Program. It was funded both by the Wellcome Trust GBT India Alliance and the Grand Challenges Canada. This was conducted in one of the southern states, Andhra Pradesh, as you will see here. And we did it in one of the districts of Andhra Pradesh, which is West Godavari. Next slide, please. The key strategies that we had as part of the project were task shifting or task sharing, and we strengthened the skills of the primary healthcare workers to provide training. So we essentially trained the lay village health workers as well as the primary healthcare doctors. Because in India, the basic medical degree that one gets while psychiatry is a taught subject, most of the medical students take psychiatry for a period when they can go on their leaves and vacations. So very few actually get trained properly in caring for mental health. So we thought it's absolutely essential that even the primary care doctors who have got a basic training in health, they also get trained in providing care for mental health. We used an electronic decision support system, which was based on mobile technology. And we also conducted a large anti-stigma campaign because, as Grace pointed out very coherently in the beginning, stigma and lack of awareness were some of the major barriers in the community. Next slide, please. As tools for identification, we used the PHQ-9, which Kari also has been using in her project, and the GAG-7. And we used both of these tools and had measures which were a kind of a composite measure to get a sense of the prevalence of depression and anxiety in the community. And these were used social health activists who are actually the brides of the village. And we also trained the doctors using WHO's MHGAP tool, and the tools that we really used were the depression and emotional disorders module, as well as the self-harm one. And Dr. Shekhar Saxena, who was at that time the director at the WHO division, was very helpful in supporting this program. We also conducted a large community awareness and anti-stigma campaign using multimedia approaches that involved printed material, videos of people with mental illness talking about their experience, a drama that involved a live performance, as well as video shows which depicted domestic violence, depression, and the need for getting treated, and obviously the training of this primary healthcare staff. Next slide. These are just some of the screenshots of the mobile-based electronic decision support system that we had. This is from the MHGAP tool that we had adapted for the mobile technology. Next slide, please. I will now basically touch upon one of our first papers that came out, which provided an idea about the prevalence of mental disorders in our community. And I have picked this up because it really shows the excess burden that is there among women in our community, even in this study that we had done. Next slide, please. So this reports baseline data from about villages, which covered about a population of 40,000. And we had screened about 28,000 adults, roughly divided between male and female. Next slide, please. What you will find that what I have circled out there in that slide is that there were obviously more women who were suffering. And the percentages, there were differences in actually the level of education. What is quite clear is that if you look at the graduates, males were more educated. There are also more males who had been educated up to high school. Next slide, please. And this actually tells you the differences between the males and females. And it's clear that females were suffering more from depression, anxiety, as well as suicide risk, and all of these were statistically significant. And if you look at the moderate and severe levels of depression and anxiety, even there, females were worse off for both depression as well as for anxiety. Next slide, please. Following the baseline data collection, we actually rolled out an intervention, which was a package consisting of our stigma campaign, as well as our mobile technology-based screening and provision of care using MHCAP. And this was rolled out in total to about 30 villages of which had tribal populations or indigenous populations, and 12 villages, as I mentioned earlier. This covered almost 50,000 population, and the total population that we screened for common mental disorders was 29,000. What we found that about 5% of the population suffered from common mental disorders, and the intervention that varied between 3 months to 1 year between the two sites. What was clear is that women were more likely to be screened positive for common mental disorders, and especially in the larger set of villages where we had the intervention for almost a year, out of the 900 who had screened positive, 70% were women. And some issues that were particularly relevant, especially related to women, where they suffered from increased domestic violence, increased stress due to the husband's alcohol use. In the tribal areas, especially, the husbands used to go out into the forest to gather food or anything, and so they used to be alone in their villages for very long periods. Women also had less access to mobile phones. That made it a problem for us to provide text-based messages to them, and that was a problem, and this actually talks about the accessibility of women. And women also at times face difficulties in seeking care, even from their primary healthcare centers, because they didn't have a proper transport or someone to accompany them. So some of the take-home messages that we can talk about today are one, that yes, women have higher prevalence of depression, anxiety, and suicide risk. However, males too have higher prevalence of completed suicides. In our study, we found that women had higher prevalence of common mental disorders. There was very specific social factors that were related to women suffering more, and access to care can be compromised among women. I think that's my last slide. Can you go to the next slide, please? Yeah, so if anyone wants to contact me, this is my email address, and thanks for listening.
You're all set if you go ahead.
Okay. Thank you very much. That was incredible and very much to time, which is great. I'm sure there will be tons of questions. So in an effort to get towards the question and answer period of our session, I will introduce our final presenter, Carmen Contreras. Carmen is a Peruvian psychologist with a master's in public health, and she currently serves as the director of mental health at Ciudad Salud, which is Partners in Health based in Peru. At the beginning of her career, she devoted herself to the study of families of hospitalized children and adolescents whose mothers were unable to care for them. She then contributed to research on prevention of adolescent drug abuse, prevention of domestic violence, and development of mental health education materials with the Peruvian Ministry of Health. For the past 15 years, she has been working at Socios en Salud, directing multiple externally funded research projects to understand and improve clinical conditions of populations affected by TB, HIV, and mental health disorders. 3 years ago, she established Socios en Salud's first community advisory committee, which reviews and contributes to all research undertaken at Socios en Salud. She is also a member of the Community Advisory Committee of Inquiry, which is the Community Research Advisors Group, the Consortium for Clinical Trials of TB, of the Center of Control and Prevention, which is the Centers for Disease Control and Prevention, CDC, which includes representatives from 5 continents and was established to increase the value and impact of TB research and interventions for the benefit of affected communities. She has directed the implementation of multiple studies and clinical interventions initiatives in Lima, Peru. And Carmen, I will hand over to you now for your presentation. Thank you.
Thank you. Could you hear me? Okay, please, next slide. We are working in Socios en Salud. Socios en Salud is part of Partners in Health from Boston. We concentrate our activities in Caraballo. Caraballo is at north of Lima. In this site, we have the overall depression prevalence 20%, and the perinatal depression prevalence is 40%. In 2018, we had approximately 4,000 pregnant mothers, and the majority of comorbidities are the TB, diabetes, hypertension, malnutrition, and we have a lot of population that are to other parts of Peru. The migration is high, mostly is more internal. Next, please. You can see in this picture our map. Caraballo are more distant, and many times the mother needs 2 hours to go to the health center. You can see the geography is very distant, and in the 2 pictures is probably the majority of pregnant needs to walk a lot of time, and they need to take, for example, bus or motorcycle, and they need to include in her day 10 soles, approximately $3 for go to the health center. Next slide, please. In Peru, in Socios en Salud, we start with a lot of projects. In 1996, we start with TV projects. In el 2000, we start the Community Health Project. In 2014, we start with Maternal and Child Project. The Mental Health Program and the Social Support Program is across to a lot of projects. The next slide, please. In this context, we start with Thinking Healthy program. Thinking Healthy is one evidence-based intervention for perinatal depression. We include this intervention in Caraballo, and our goal is to reduce perinatal depression in the woman, and we include the pregnant mother that I have in 7 months of pregnancy. Next, please. The implementation process was so large. No, we have a lot of time to include a lot of activities. For example, we reading, we lecture of all the manual, and then we have Skype calls with teams in Pakistan and Bolivia who have implemented Thinking Healthy. Then we provide training to the community health workers. Then we implement one pilot group on thinking healthy, and then we continue with meetings with community health workers. This picture is to show how or where is living the mothers. You can see the picture, and our professionals go to the house, to the mother, and we working very close with Minister of Health, but they didn't have time for go to the house, and our team, our members of our team go to this house every day or every week, depend the schedule that we had with the mothers. Next, please. I can explain that our program is working together with other projects. The first project is the Maternal and Child Health Program. SAMI is the acronym. And in this project, we provide support to the clinical aspects. We register all the clinical information. Then we monitoring prenatal checkups. In Minister of Health requests 6 prenatal checkups, and we emphasize to the mother that they need to go to 6 or more prenatal checkups. And our community health worker accompany all the mothers in all the process, and we provide nutritional counseling with nutritionists that work in Socios and Salud. This is our schedule. We include the pregnant and the mothers. We include the part clinical, nutritional, and emotional aspects in every pregnant mother that we enroll to our project. Next, please. This is the preliminary results. We are working in the last results. We can show the total, the 103 pregnant women. You can see that the 28% had is with depression and 72 without depression. The next, please. Sorry, okay. The level of depression you can see in this slide. The majority is minimal or mild depression. The moderate or mild grade depression is so the moderate major depression is less, but with this mother we need to refer to the health center because we don't have in our team psychiatrists, and we need to work very close with the health center. Next, please. The next slide. And you can see the other problems that we detect at the enrollment moment, and the drug use and the violence in the last year, or the sometime of violence in childhood is too high. And we had problems with poor sleep quality too. And in the first, second, and poor sleep quality, we refer the majority of times to the health center. And in another time, we refer to the hospital because in the health center, we don't have psychologists or psychiatrists, and we need to refer to the hospital or the Institute of Mental Health. Next slide, please. Please. Okay. You can see in this slide the number of pregnant women who receive session. Sometimes the pregnant mother retire, abandon the intervention. The majority of time is because they left the area that Socios and Salud interview, or sometimes they don't want to participate in the intervention, they don't continue, or they don't have time because they include in the activities the job. Next slide, please. And when we reevaluate the pregnant mother with PHQ-9, you can see the change. You can see when the mother reduce the depression, according they continue the intervention, thinking healthy intervention. The next slide, please. This is a picture. The picture is our training with community health worker. We received the visit the WHO representatives. They was very interested in to continue. And the other is more picture. And I think this is, I have one slide more. Okay, this is the last picture with the first baby in our project. Thank you.
Great, thank you very much, Carmen. That was really, really, really great. I think we've got quite a few sort of questions, and we are running a little bit behind, but we will try to prioritize some of our questions for the speakers who have to leave right at 3:30. And just to say that if there are other questions in the audience, we will give a little bit of extra time after that to take additional questions for those speakers who can stay on. So I think our first question is to all panelists from Purnima. And the question is, if violence is such a major driver of depression in women, which sort of is something that seems to come across all the presentations, it seems that we need to not only treat women, but create interventions that can help reduce violence in communities. Can comment and share their thoughts. I think this is a really important question that tries to tie together the need to think about how illness and conditions intersect and within the world around us, and how people live through context. So it would be great if some of the organizers could speak to that. Why don't we start with Kari?
Sure, thank you. I mean, I think that the short answer is yes, which is why I think we include men and boys, despite our focus on women. We want to ensure that everybody in a given community has emotional literacy and skills and care. It's a harder question to answer in terms of kind of addressing societal norms of violence, but the skills that are developed that we try and foster in our group talk therapy, which is based and sort of centered around relationships, can also kind of bring a certain amount of skill building around how do you handle conflict safely and effectively, and without having to resort to violence, and can those skills not only be something that you practice and work on during the course of your therapy, but also that you take forward and can draw on in the future.
Great, thank you. Pallab?
So I would disagree here a little bit by saying that sexual violence is, I don't think can be considered as the #1 risk factor for mental disorders in women. There are other risk factors also, but definitely it is an important risk factor. And I think that in any intervention or any study or any program that is done around domestic violence or sexual violence, I think I think it's the community as a whole that needs to be treated, both men, women, and the police and everyone. Everyone needs to be more aware, understand the issues, and get treated or get or made more aware of the problem. So it's a much more holistic approach that we need to do.
Great. Carmen, would you like to speak to that question?
Might be helpful for other sites too.
Hello?
I just wanted to clarify in your outline.
Can you hear me?
Have 5 days of training for the training.
Carmen, yes, we can hear you. Please go ahead.
Sorry, I didn't hear very well the question, but I am reading some question about the training that we receive from Pakistan team. And my answer is that we talk with the team in Bolivia and from Bolivia team and from Pakistan team, and we learn more about that. And then we include some changes in the protocol, in the manual, and then we include one pilot. According the question about the violence in the women, we include one package with Minister of Health to provide support to this mother, because how Socios en Salud connect different sectors, the Minister of Health, just minister, and they provide support to all mothers that had experience in abuse or violence in Peru.
Okay, great. Thank you, Carmen, and thank you for speaking to that other question about training as well. I have another specific question for Pallab. And the question is, are any, I think it's sort of speaking to your experience as a psychiatrist, a practicing psychiatrist. And the question is, are any of these interventions sort of suitable on their own for people expressing suicidality? Or would you sort of recommend combination with medication or referral outwards to additional programs, typically in these cases?
So I think a short answer to that is it's a combination of both psychotherapy as well as pharmacotherapy. There are specific indications for pharmacotherapy, and there are specific indications for psychotherapy. And to say that pharmacotherapy is not at all essential is not right, because there are definite cases where pharmacotherapy is definitely needed. And in the most severest of severe cases, even electroconvulsive therapy, because it has got its own reasons for being used in some of those most extreme cases when it can be life-saving. And so the answer is that it's a combination of both.
Okay. Great. I have a couple questions for you now, Kari. The first is from one of our attendees, Christopher Laurie, who asks, does the adolescent pilot program address societal factors which may precipitate mental health disorder signs and symptoms in adolescents? And the second, from another attendee, is about following the completion of the pilot program. Were you able to record or notice an impact of the IPT on other aspects of children's lives beyond their mental health? So thinking about wider community networks such as families, social circles, and so on.
Sure, thanks so much. Those are both really great questions and difficult questions. So are we addressing societal factors? I think yes, in that the work of the therapy that the kids participate in is about really focusing on what's happening in their lives and happening in the here and now. That's sort of a calling card or an attribute of IPT. I think in terms of the bigger picture, we do know that abuse and stress, lack of sleep. Lots of factors are kind of really common in this population of low income kids in this particular community in Uganda that I think are definitely driving and playing a role, contributing to their mental well-being. And so in the course of therapy, in the course of psychoeducation, and in our presence within the schools, we are looking to really, where there are opportunities to speak about self-care, good sleep, managing stress, certainly referring, we have very strict protocols in place to ensure child protection. And in the case of any instances of abuse, assault, et cetera, we can, that's unfortunately not prevention, but it is a clear response. I think there's room to do a lot more and to be thinking about the therapy in the broader context. I think where we're starting with is with, something that responds to the acute needs in a context where kids aren't aware of the illness and don't have access to the care. I think to address the question about, are we looking at other factors and other measures of well-being? Absolutely. One of the findings from our time where we spent, sort of designing and working with kids themselves was, we know that substance abuse is an incredibly prevalent challenge. And so I do not have the data yet, but we were looking to understand sort of to what extent might substance abuse patterns have changed as a result of the therapy. We need a little bit more time. We're hoping to circle back with these kids after 6 months so that we can have a little bit more time for some of those behaviors to have hopefully taken root. We're also looking at some very basic sexual and reproductive health and related behaviors, such as use of contraception and sexual sort of decision-making, as well as sort of general parameters of school attendance and performance at this stage. And sort of what we've learned, I think, may inform where we look and investigate in future.
Great, thank you very much. I noticed that now a lot of really great questions are rolling in, but unfortunately we are sort of running towards the end of our time here, so we're going to have to wrap up. I would sort of encourage those who have asked questions and have not been able to share them today, if we could please forward them our speakers via email. And thank you so much to all of our speakers for your amazing presentations. I think lots of great food for thought on so many levels, thinking about challenges of gender and women, and sort of moving beyond that to think about context and communities as part of our efforts to address mental health and specifically depression in the global south. And so I will now hand over to Alyssa to do our final wrap up and discuss next steps moving forward. Thanks very much, everybody.
Thanks so much, Rochelle, and thanks so much to everyone who's joined us. My name is Alyssa Chase-Filches, and I am the UK Program Manager for the Women's Global Health Program here at the George Institute for Global Health. I just wanted to extend a warm thanks to my colleagues who helped organize this event today, Emma Feeney and Anna Bertrand here at the George Institute, as well as our partners at the WHO's Global Coordination Mechanism for NCDs and our excellent steering group who helped develop the concept for today's event. And of course, I want to extend a huge thank you to Dr. Rochelle Burgess and to all of our speakers. We're very keen to keep this conversation going, and we're so excited to see all the great questions that have been rolling in on the discussion board. So you can see on the screen now that there's directions to how to enter our knowledge action portal for our community and women in NCDs. We'll be posting a recording of our webinar there. And after this webinar, I'll send you this information to everyone who's registered by email. We'll be, as I mentioned, posting both the recording, and there's also an opportunity to post discussion questions there so that we can keep this conversation going. Once I sent that email out, if you do have any questions or comments specifically about the webinar, or if you have any ideas for other topics that we can cover in this series, again, with the focus on women NCDs, please do feel free to share it with us. In regards to today's specific webinar,
We plan to summarize the lessons learned, both from the conversation from the webinar itself, as well as from any key points that we get from the discussions on the community's platform. And we'll be taking those conversations and turning it into a blog entry, as well as a series of short podcasts. So that's it in terms of updates. Thank you so much for attending. And I know that we're a little bit over time, but we really appreciate the time you put in to participating in today's event. And please enjoy the rest of your day. Goodbye.